Okay, that brings us to chapter 4, which is the spine. Here's an introductory image, which the book has, let me go back, about the spine. And as you can see, there's some abnormalities here, some trauma that has actually happened. We have a rib fracture here at the costovertebral joint. We also have a fracture running here of lumbar vertebrae, one running here, one running here, and then we also have fragmentation back into the spinal canal. And we also have possible fracture here and here. And so as a result of that, we could have serious compression of the spinal canal and serious impairment of the patient's nervous system, just simply because of this. So it's very dangerous. Spines are sometimes hit or miss. Sometimes we see a lot of pathology, sometimes we see no pathology. And that's kind of one of the hit or misses in terms of viewing the spine. So I'm sure we all have a pretty good grasp on what the spine actually does. And we know that, just to begin with, the vertebral column is a remarkable structure. It supports the weight of the body, helps to maintain posture, and protects the delicate spinal cord and nerves. So it has three functions here. And as we can see, it does these quite beautifully. It's made of 33 vertebrae, so know this, that there's 33 vertebrae. There's going to be 7 in the cervical spine, 12 in the thoracic spine, and 5 in the lumbar spine. And then that brings us a total of 24. And then there are basically 7 segments for the sacrum and coccyx. We also see that we have a lordotic curve, which is the cervical and lumbar spine, and kyphotic curve, which is the thoracic and sacral curvature. So basically we have a spine that looks something like this. And so this being your kyphotic curves here and here, and this being your lordotic curves here and here. And that'll become more apparent as we actually venture through our scans. A typical vertebrae consists of 2 main parts. We have the body, which is the anterior element or the anterior portion, and this is in charge of supporting the weight of the body. And so this is why any abnormalities to the vertebral body can cause serious damage to other parts of the vertebrae as well. The vertebral arch, posterior element, and it attaches to the sides of the body and forms the vertebral foramen or foramina. And the succession of vertebral foramina forms the vertebral canal, which contains and protects the spinal cord. Sometimes this vertebral canal is used interchangeably with the spinal canal, and that's perfectly fine whether you want to interchange those or not. But just know that it takes both the anterior and posterior portions of the vertebrae to actually form this spinal or vertebral canal. So here we have the lordotic curve, the cervical curvature, the thoracic, which is the kyphotic curve, lumbar vertebrae, which is the lordotic curve once again, and kyphotic curve of the sacrum and coccyx. So here is basically what a typical vertebrae looks like. So we have pretty much a dividing line here between the anterior element and the posterior element. We see that the arch, pretty much this area here, makes up the posterior element. As we can see, the vertebral body is quite large, and it serves its function of basically supporting the weight of the body. To attach the arch or to make up the first segment of the arch, we have the pedicle, and then we have the transverse process here, and this is bilaterally, and then to connect from the transverse process to the spinous process, we have the lamina, which is this area here. So this area and this area are the lamina, and they merge together to form the spinous process, which is the most posterior portion of the vertebral or of the vertebrae in general. Also, we have the superior articular process here bilaterally, and on the underside of it, we actually have the inferior articular process. So once we've seen this on a drawing, we notice that the vertebral arch has two pedicles which project from the body and connects to the lamina. They contain upper and lower vertebral notches. When these notches are joined, they form intervertebral foramen, and they allow spinal nerves to pass through. So the intervertebral foramina is simply for the passage of nerves through the vertebral bodies or through the vertebral arches. The vertebral arch also has two laminae, which continues posteriorly and medially, and it forms the spinous process. So as we saw, they converge together to form the spinous process. Also, we have one spinous process, which is the most posterior portion of the vertebrae at all. And we also have two transverse processes, which project laterally and occur where the pedicles and lamina join. So basically, we have something that looks, I realize this is a very crude drawing, but we have the lamina and the pedicles joining together to form the transverse process. So we have the pedicles, lamina joining together, transverse process, and then the two lamina joining together to form the spinous process. And all of this makes up the vertebral arch, or the posterior element. Also, the vertebral arch has two superior articular processes and also two inferior articular processes. The zygapophyseal joints, or the facet joints, are formed from the articulation of the superior and inferior articular process. So the zygapophyseal joints are formed from this union of the superior and inferior articular processes. And they are charged with providing support and vertebral movement for the body. So you can't just have, as we all know, having a spine that's a very rigid structure just doesn't work. So having the ability to move around and bend and straighten up your back and things like that, that's very important, and it's because of these zygapophyseal joints that this is allowed to happen. If the vertebrae were the only thing that were holding, if the vertebral body were the only thing that were holding the vertebrae together, then it wouldn't be very effective. Things would be grossly ineffective, actually. But also, we have intervertebral disc, which is the shock-absorbing part of the vertebrae, or situated in between the vertebral bodies. And it's made up of two parts: the nucleus pulposus, which is the soft central semigelatinous material, and the annulus fibrosus, which is the firm outer portion. And so, basically, I don't really know what cervical vertebrae is doing here, but basically, you have two layers of an intervertebral disc. You have an inner and an outer. The nucleus pulposus is the inner, and the fibrosus is the outer portion. If we look at the name, the fibrosus implies that it's a hard, rigid structure, and because of that, it kind of is in charge of keeping the gelatinous structure in place, and so basically don't have the gelatinous structure kind of going every which way, but it keeps it in one localized area, and so it provides excellent amounts of cushion. So here is what this actually looks like on CT. Notice that we are at L5, and at L5 we're seeing that we have the vertebral body, which is the structure here. Then we have the pedicle, and the transverse process. Then we have a lamina bilaterally, converging together to form the spinous process. This image looks very interesting because we have something inside the spinal canal, which I'm kind of anticipating this being some type of contrasting material based on what we're seeing. So this could be something like a myelogram, something to that. Here we have a sagittal or a side view, and notice that we have the inferior vertebral notch here, and so we have the inferior articular process and the superior articular process. And so those two come together to form the zygapophyseal joint. We see the transverse process here, spinous process here, and so this means that this area here is the pedicle. Also, we have the body of the vertebrae, which is pretty much comprised of this entire area here. We have a vertebral end plate and a vertebral end plate, and basically what that's saying is the end plate is the top and bottom portions of the vertebral body. Also, we have the inferior costal facet, and a superior costal facet, and so that is what basically we have for articulations for the ribs. If this is a trans or a thoracic rib or a thoracic vertebrae, which is articulating the thoracic rib. Here we see that we have the thoracic vertebrae, and as you can see, you have superior and inferior costal facets. Typically, these will not be demonstrated on any other vertebral bodies other than the thoracic. One thing to notice is that we have the zygapophyseal joints here, and it continues all the way down. And also we have, based on the zygapophyseal joints and the vertebral body, it creates the intervertebral foramina, which, as we saw previously, it allows the passageway of nerves through this area. Also, we have vertebral body, pedicle, transverse process, spinous process, and I do believe that is it. Also, we do have the intervertebral disc, as we can see, and it'll be demonstrated on CT as well. So if we look a little more closely, we have the cervical vertebrae, the thoracic vertebrae, the lumbar vertebrae, and then we get into the sacrum and coccyx. So if we first begin by looking at the cervical vertebrae, we see that we have 7. They have transverse processes which contain a transverse foramen. So that's something to keep in mind, the transverse foramen. And allows for the passage of vertebral vessels. As we saw in our previous lecture, things like the vertebral artery run through this foramen. And the first cervical vertebrae is called the atlas. The atlas coming from the mythology of the Atlas, or the man which supported the world. And as we see, the atlas supports the head. It has a superior articular process which articulates with the occipital condyles of the skull. And this forms the atlanto-occipital joint. Keep this big word in mind. The atlanto-occipital joint means the articulation between the atlas and the occipital bone. It has no body and no spinous process, so it's unlike all the other vertebrae in regards to that it doesn't have these two things. So put a star beside this, because it's very important to differentiate between the atlas, the axis, and all the rest of the cervical vertebrae. It consists of an anterior arch, posterior arch, and two large lateral masses. And it's because of these lateral masses which we have the ability to basically bear the weight of the skull. A second cervical vertebrae is different too. It's called the axis, and it has a large odontoid process, which is called the dens, and it acts as a pivot for rotational movement of the atlas. And so basically, it is the point where the atlas kind of hinges and allows rotation of the head. The cervical vertebrae, C3 through C6 have unique configuration with their bifid spinous process. When we're saying bifid spinous process, we typically think of the spinous process looking something like this. However, C3 through C6 has a bifid tip, which means that it's something like this. And so you have an indentation here. The seventh cervical vertebrae, or the vertebra prominens, has a long spinous process that is typically not bifid. So we see that C3 through 6 is this type, but C7 typically resorts back to this. This spinous process is easily palpable posteriorly at the base of the neck. So you're going to look for C7 at the base of the neck. You can probably reach around to the back of your neck right now and feel the vertebral prominens, because it's very prominent in every individual. So that brings us to what it looks like on CT. If we'll go by what we're seeing here, this is an oblique type of image. As we are running in an oblique plane through this, we're not running coronal or axial or even sagittal. So, and the reason that we can say this is because we see the intervertebral foramen, and we do see the zygapophyseal joints. And so, because we can see the intervertebral foramen, we can assume that this is oblique. And one thing I want to add is that on your best day of shooting an oblique cervical vertebrae, you probably have never got your intervertebral foramina to look like this. You've never seen them in this kind of definition. And so that's why CT has kind of taken the wind out of the sails for just traditional routine conventional radiography in terms of cervical imaging, because we can actually see all of this to a higher degree of detail and do it probably at the same rate that we could actually get all these pictures shot for cervical spine. So with that being said, we have the odontoid process here of C2. So we're going to say this is C2, 3, 4, 5, and C6. We do have disc here, 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 and here. We do see C1 here, and so we are seeing intervertebral foramina, and we're seeing the zygapophyseal joints here and here, and even here. And so basically what this is used to demonstrate is the intervertebral foramina. We go back. Okay, this is basically C1. So probably want to write that on your PowerPoint, but this is C1. Notice we have an anterior and a posterior arch, and so basically we don't have a vertebral body, but we have this big, huge open spot on the inside. And so this is where you're going to see the odontoid process, or the dens of C2, actually reside. And then there's going to be ligaments that help to hold this together and everything. But for the moment, let's just focus on this. We have the anterior arch, which would be this entire structure here. And then we have the posterior arch. And so pretty simple up to this point. We have the superior articular processes. And this huge area pretty much comprised here is the lateral masses. We do see that we have a transverse process, which is basically formed from the union of the anterior and posterior arches. And we do see that we have the transverse foramen, essential for the cervical vertebrae to actually allow the passage of arteries and other vessels up. Here we see C1 and CT. We have the transverse foramen here. We have a transverse process. We don't see it on the left side. We have the anterior arch here, and then we have the posterior arch. We have the superior articular process here, and then moreover we have the big lateral mass here. Also, we do have the odontoid process sitting inside, and if you'll notice, it might be a little hard to see on your screen, but we have what looks to be a darker or hypodense circle here, situated on the inside, and that is where the spinal cord is coming up and getting ready to enter into the skull. I believe that is it for that image. So this is C2. C2 is unlike anything that you've seen as well because it has this large process, which is the odontoid process. You still have the superior articular processes and the inferior articular processes bilaterally, but you do have a body here. It doesn't typically look like your traditional vertebral body, but it still maintains the same functionality, which is supporting the weight of the skull and allow pivoting because of this odontoid process. Here is what it looks like in terms of CT. We can see we have the odontoid process here. So all of this is the odontoid process. We have the body, C2. We have the superior articular processes. We have the intervertebral disc, and we have to look at C1 as well. We're looking, getting ready to go into the posterior arch of C1, but we do have the lateral masses. And we do have the occipital condyles here, and the superior articular processes there. The transverse process of C1 bilaterally. And I believe that is it. Here's a sagittal view of C1, 2, and 3. We have the anterior arch of C1 here. Then we have the posterior arch. We can see that we have a hypodense area here, which is the spinal cord or the spinal canal. We'll say canal because we can actually not get the exact or the proximity of the spinal cord. We have the odontoid. And we have the body of C2. This is the spinous process. As you can see, it's kind of blunted and it's not as prominent. Then we have, as we get into C3, we actually have a traditional body and spinous process. Also, we have the vertebral end plate here and here. Also, we have the pharynx. We have the epiglottis. And I do believe that is it for that image as well. So this is kind of a crude drawing of what C1 and C2 and their relationship actually looks like. We have superior articular process of C1 and the inferior articular process of C1, superior articular process of C2, and the inferior articular process of C2. We have the bifid tip, as you can see here. And notice how the odontoid is actually situated on the anterior, more towards the anterior arch than the posterior arch. We have the transverse foramina, once again to allow passageway of vessels. We have the transverse process. And we have the intervertebral disc. Okay, so here is a sagittal view of C2. So once again, this is C2. You can tell this because you have the large odontoid process. You have the superior articular process and the inferior articular process. The transverse foramen, transverse process, spinous process, which looks strange on this. And then you have your vertebral arch here. So that brings us to a traditional vertebral area, traditional vertebral layout for cervical vertebrae and pretty much for the rest of the body, with certain exceptions like the transverse foramen. So we do have the superior articular processes here. We have the pedicle, the lamina, the bifid tip spinous process. We have the body, and we have the transverse foramen. And this one doesn't have a very prominent transverse process. Be very easy to kind of overlook that because you would typically think that this would be more accurate for the spinous process. But it will become more easy to distinguish which is which. Here's a sagittal view. And we see that we actually have the spinal cord here, and we have subarachnoid space or contrast in the subarachnoid space. And so we have differentiation between the spinal cord and just the subarachnoid space. We have C2, 3, 4, 5, 6, 7, and we've actually got down to T1. We can see that we have the bodies, we have the intervertebral disc, and this contrast inside of subarachnoid space actually allows us to see whether there is any significant disc bulging, and if there is, to what degree. And as you can see, there might be a slight disc bulge, but not much at all in terms of this. Nothing certainly to encroach the spinal canal. Also, we have spinous processes from C2 through pretty much C7. I notice how C7 has a very elongated appearance, and that's why it makes it prominent, or as we call it, the vertebral prominence. Okay, we have contrast in subarachnoid space as well here. And so that is what we're typically seeing in the screen. But we do have the vertebral body here. We have, really we're not seeing the pedicle very well, but this looks like it might be the transverse foramen. And so the pedicle would be somewhere in here. And we're seeing this area being the lamina, which brings us to the bifid tip of the spinous process. Here is C7. Thus we have the internal jugular and common carotid being here. The transverse foramen. We have the body, transverse process, pedicle, lamina, spinous process, and we'll say vertebral canal. And I believe that is pretty much all the relevant images, structures on this image. So that brings us to the thoracic vertebrae. The thoracic vertebrae, as the name implies, is the thoracic vertebrae, or the vertebrae that comprise the thoracic area of the body. There's 12 of those vertebrae, and they have demifacets that articulate with the ribs. We have costovertebral joints, which is where the head of the rib articulates with the vertebral bodies. We have the costotransverse joint, where the tubercle of the ribs articulate with the transverse processes. And we have the spinous processes being typically long and slender. And so your spinous processes sometimes will give you clues to where you actually are when you're scanning through. Remember that the cervical vertebrae C3 through 6 or C2 through 6, to be more correct, are bifid in nature. C7 is very long, and what you see in C7 is kind of what you see as you go down through the thoracic vertebrae. They're going to just be very long and slender. They're not going to be bulky like the lumbar vertebrae actually are. And so here we see the body of a thoracic rib, and we're seeing something different here, kind of a little different layout. We have the body, we have the pedicle, we have the transverse, lamina, spinous process, but then we also see that we have articulation with the rib. And so, as the name implies, costovertebral joint, which is the joint between the rib and the vertebral body. So, and then we also have the costotransverse joint, which is the name implies, is the articulation between the rib and the transverse process of the vertebrae. So what it actually looks like in CT is always different than what it actually looks like in a drawing. You can make a drawing look however you want it to, but CT is vastly different. So we see that we have the body, this area. We have the pedicle, the lamina, the transverse process, spinous process, and we have costovertebral joint and the costotransverse joint. Very important to keep these in mind because you will be seeing these later. That brings us to the lumbar vertebrae. As we all know, there are 5 lumbar vertebrae, and they're large in terms of body type. They are very bulky, and the largest is L5, which is where all of the weight of the upper body is actually placed. When you hear a lot of people talk about having back pain, one of the most obvious instances or most obvious places to look for lumbar pain is simply L5S1, and that's because L5 has all of the weight of the upper body placed on it. And so if you weigh or if you're overweight, then you have a lot more weight actually bearing down on this joint, and so it's wearing out this disc base to a higher degree. And so typically L5 is where you're going to see a lot of abnormalities. That's not to say that there's not abnormalities that go well above L5, but L5 is a very common place to see abnormalities. So we're looking here, and we see that we have contrast inside of this area. We have the disc. Notice how when you're going through the disc base, you're actually seeing something that looks kind of like a double layer area. This is the nucleus pulposus, which is the gel, and this is the fibrous or tough layer, or the annulus fibrosus. And so we do also see that we have the superior articular process and the inferior articular process of the vertebral areas. We have the spinous process here, and that is pretty much it for this. So, as we know, 3D reconstruction has kind of called on in terms of looking at the spine. And so we start by labeling L5, L4, L3, L2, L1, and sometimes volume rendering is excellent, sometimes volume rendering is not. Yeah, a lot of it is based on whether the patient has enough calcium in their bones to actually demonstrate excellent anatomy. Usually this doesn't work so well in older patients because they don't have enough calcium in their body to actually support doing this, because everything just kind of gets, for lack of a better term, kind of grainy and just unappealing in terms of the way the images actually look. You actually cannot distinguish anything. So looking at this, we have the body, which we're seeing. We're looking in the anterior, anterior, posterior, or AP view, and we have the transverse processes here. And we have the intervertebral disc base, but one of the many problems with volume rendering is that when you focus on the bone, you tend to lose the disc, and so sometimes it becomes very difficult to actually demonstrate where an abnormality is, because when you're looking at a volume rendering, it's usually typically for bone or bony problems. Also, one thing that I forgot to mention is that the lumbar spine has 5, but I've seen several instances where you have 6 lumbar vertebrae, and that's usually because one of the areas of the sacrum, S1, has not actually formed with the sacrum correctly, and so it kind of tricks you into thinking that you have that being L5 instead of the true L5. And so the rule of thumb there is I usually just scan all 6 of the lumbar vertebrae, because you're trying to get all of this area. So you want all of that area, or as much as you can get. So here is a sagittal view. As we can see, we have the vertebral end plates here. We have the body. We have the pedicle. Then we have the transverse process coming out here. Spinous process, inferior articular process, superior articular process, inferior vertebral notch, and the superior vertebral notch, which are going to help create the intervertebral foramen. So here is an axial image, pretty much cut and dry. We have the body, transverse process, spinous process, the lamina, and the pedicle, and the vertebral canal. Very simple here. Also, as we're looking at it, we have kidney here, which this would be the right kidney, this would be left kidney, aorta, once again, we've kind of seen this image tossed around. We have the body, lamina, pedicle, or sorry about that, I got ahead of myself. This is pedicle, this is the lamina. Spinous process, transverse process, contrast in probably the subarachnoid space, psoas muscle, psoas muscle. So that brings us to the sacrum, which consists of 5 fused vertebrae. Lateral masses, or the ala, articulate with the pelvis, and it forms the sacroiliac joints, or the SI joints. And it contains sacral foramen, which allow the passage of nerves. The first sacral vertebrae has a sacral promontory, and it separates the abdominal and pelvic cavities. So, looking at the sacrum, we have sacral foramen, or foramina here. And so we have 5 levels. 1, 2, 3, 4. 4 different spaces, which makes this level 1, 2, 3, 4, 5. And so, kind of hard to distinguish where these levels actually are when everything is fused together. And so you do have the ala, or the lateral mass of the sacrum, being here, which forms the SI joint. And then you do also have the coccyx here. And here is kind of an oblique, if we're actually just having the patient lay flat on the back and we're scanning coronally through. But notice that this is the correct view to actually see the sacral foramina. And I challenge anyone to have actually shot a better sacrum and coccyx than what you will see on CT, because there's no way that, on your best day that you could actually achieve this with conventional radiography. I've shot some good Sacrum and Coccyx, and I've shot several bad, just simply because you're obscured by the patient anatomy, whether it's the patient's too large or the patient has a lot of fecal material, and there's no way that you can actually go in there and shoot this and get a good image. So this is typically, if you want to see abnormality, this is going to show you the best. Here we have L5, and so this makes this S1, S2, S3, S4, S5. The reason we can say this is because we actually do see the dividing line here where they're fused. We do see the sacral foramina. The SI joints here, the ala, or the lateral masses, L5S1 intervertebral disc, and also the sacral promontory, which is really not demonstrated very well on this image. Here's S1 once again. We actually do have contrast medium still here. We have the sacral promontory here, which is the most prominent portion jutting out anteriorly. The SI joint, ala, or lateral mass, here, here, and we do have the ilium here. That brings us to the coccyx. The coccyx contains 3 to 5 bony segments and is most inferior portion of the vertebral column. So that brings us to ligaments. We have several ligaments that actually run through the spine, and very important. We have the apical ligament, which is the midline structure that connects the apex of the odontoid process to the anterior margin of the foramen magnum. So this is going to be in C1, and very important to hold everything together. The alar ligaments are 2 strong bands that extend obliquely from the sides of the odontoid process upward to the lateral margins of the occipital condyles to limit rotation and flexion of the head. Have you ever wondered why your head just doesn't, why you can't turn your head 360 degrees around and things like that? Well, it's simply because you have ligaments that prevent you from doing that. Because if you were able to turn your head 360 degrees around, you would pretty much disassociate your spinal cord from the rest of your body, and that wouldn't be good. And so basically it is because of these ligaments that you don't ultimately wind up damaging yourself. The transverse ligament extends across the ring of C1 to form a sling over the posterior surface of the odontoid process. So basically you have anterior arch, posterior arch, the odontoid sitting in here, and then there's this transverse ligament which kind of runs along the ring of C1 to hold the odontoid process in place, to keep it from moving all over the place. It has a small band of longitudinal fibers that ascend to attach the anterior margin of the foramen magnum, and inferiorly to attach to the body of the axis. It functions to hold the odontoid process of C2 against the anterior arch of C1. That's why you can't have posterior slippage of the odontoid process inside the ring of C1. If you do, then there's probably some really horrific abnormality with a transverse ligament. Sometimes called the cruciform ligament. The ligamentum nuchae acts as an attachment point for muscles. It extends from the external occipital protuberance of the cranium to the spinous process of the cervical vertebrae. The supraspinous ligament is a narrow band of fibers that runs over and connects the tips of the spinous processes from the 7th cervical vertebrae to the lower lumbar vertebrae. So it runs from C7 to the lower lumbar vertebrae, which we take that to be very low. The anterior longitudinal ligament is a broad fibrous band that extends downward from C1 along the entire anterior surface of the vertebral bodies to the sacrum, and it connects the anterior aspect of the vertebral bodies and intervertebral disc to maintain stability of the joints and to help prevent hyperextension of the vertebral column. You don't want hyperflexion, nor do you want hyperextension, because that damages all of the associated mechanisms that make the body work. And so because of that, these ligaments help to do that. The posterior longitudinal ligament, which is narrower and slightly weaker than the anterior longitudinal ligament, it lies inside the vertebral canal and runs along the posterior aspect of the vertebral bodies. It's attached only at the intervertebral disc and adjacent margins. It runs the entire length of the vertebral column beginning at C2. This is pretty amazing to check out. Put a star by it, that it runs the entire length of the vertebral column. The only place that it doesn't extend to is C1. And it functions to prevent posterior protrusion of the nucleus pulsus and hyperflexion of the vertebral column. So we prevented hyperextension and hyperflexion, and so you're trying to keep all of the disc in place. Also, we have the ligamentum flavia, which are strong ligaments consisting of yellow elastic tissue present on either side of the spinous process. They join the lamina of the adjacent vertebral arches and help to preserve the normal curvature of the spine. So that's what you want to know, is this last bullet point for the ligamentum flavia. So here is an actual diagram of what the disc base actually looks like. As we saw before on CT, you can see the inner ring, or the inner area, which is the nucleus pulsus. And then you have the annulus fibrosus on the outside, being the hard area to actually keep the gelatinous structure in place. We do see that we have a cauda equina, which is typically referred to as the horse's tail, because all of the nerves typically have spread out and branched out, which is what we're seeing here. Then you have the spinal nerve root, epidural space, things like that. Here we see pretty much some of the ligaments. We have the apical ligament thing here, the anterior atlanto-occipital membrane, the ligamentum nuchae, the anterior longitudinal ligament running down this way, and the posterior longitudinal ligament, which is running here, beginning in C2. And so as you can see, it kind of traps the intervertebral disc in its place to keep it from going anywhere, and also creating something that kind of holds the vertebral body in place. Here we can kind of see the anterior and posterior longitudinal ligament. There. We do have the vertebral canal, spinous process, C1, C2, C3, and then we have the anterior arch being here, and the odontoid process being next to the anterior arch, and then we have this, which is the transverse or cruciform ligament, which keeps the odontoid process from moving to the posterior portion or the posterior arch. Here we kind of see how everything is actually laid out. We have the transverse ligament, and so because of this, we're looking at this from a PA perspective. We have the odontoid process sitting inside. We have also the Lumbar ligament and the longitudinal band of the transverse ligament, which allows this to kind of stay in place. So here we actually see CT. We have the transverse ligament running here, the odontoid, anterior arch, posterior arch, spinal canal or vertebral canal. This is probably spinal cord here. Have trachea, or better, this is let's say oropharynx to be more accurate at this point in juncture. Here we have the anterior longitudinal ligament, and we have the posterior longitudinal ligament. And as you can see, it kind of just compresses everything and keeps everything working together so that one doesn't slip from the other. And then we also have the ligamentum flavium. I think this image kind of really demonstrates this very well. You have the anterior longitudinal ligament, the posterior longitudinal ligament. You have the intervertebral disc, which we're not going to worry about the hyaline cartilage, or we're just going to worry about the nucleus pulposus, which is here, and the annulus fibrosus, which is the tough outer layer. Then we do have ligamentum flavia, spinous process, lamina, and the pedicle. And I do believe that is all that we need to actually understand from this image. Here we have the posterior longitudinal ligament. Really can't demonstrate the anterior longitudinal ligament unless this is it. Then we have ligamentum flavia, which is on the posterior portion of the arch. And then on spinous processes, we have the ligamentum nuclei, or nuchal. Also on this image, we have the internal jugular, common carotid, thyroid, trachea, esophagus. Okay, so the superficial layer. Splenius muscles located on the lateral and posterior aspect of the cervical and upper thoracic spine. They originate on the spinous process of C7 through T6 and the inferior half of the ligamentum nuchae. It's divided into the cranial portion, splenius capitis, that inserts on the masculine process of the temple bone, and a cervical portion, splenius cervius, that inserts on the transverse process of C1 to C4. And all you really need to know is that the splenius muscles act to extend the head and the neck. Also, the intermediate layer, the erector spinae muscle, consists of massive muscles that form a prominent bulge on each side of the vertebral column, a chief extensor of the vertebral column, and they're arranged into three vertical columns, the iliocostalis layer, or the lateral column, longissimus layer, or the intermediate column, and the spinalis layer, which is the medial column. This muscle group arises from the common broad tendon from the posterior part of the iliac crest, sacrum, and inferior lumbar spinous processes. And basically, what you need to know about the erector spinae muscle group is they are the chief extensor of the vertebral column. The costus muscles run superiorly to the angles of the ribs and transverse processes of C7 through C4. The longissimus muscles run superiorly to insert into the tips of the transverse processes of the thoracic and cervical regions, the angles of the ribs, and the masculine processes. The spinalis muscle group extends from the spinous processes of the upper lumbar and lower thoracic regions to spinous processes of the superior thoracic region. The deep layer, the transverso spinal muscles, consist of several short muscles that are located in the groove between the transverse and spinous processes of the vertebrae. They can be separated into the semispinalis, multifidus, and the rotaries, and the primary function to flex and rotate the vertebral column. So once again, just know the function. The semispinalis muscles arise from the thoracic and cervical transverse processes and insert on the occipital bone and spinous processes in the thoracic and cervical regions. They form the largest muscle mass in the posterior portion of the neck. The multifidus muscles consist of many fibrous bundles that extend the full length of the spine and are the most prominent in the lumbar region, best developed in the thoracic region. So here's a demonstration of kind of how everything is laid out, but we're not going to worry about this image, so you really don't need to know anything. We'll kind of skip over this, and we'll skip over this one as well. More importantly is the spinal meninges. The spinal cord is surrounded and protected by cerebrospinal fluid. There is a thecal sac which contains cerebrospinal fluid, and the spinal meninges are continuous with the cranial meninges and can be broken into the same three layers, such as the dura, the arachnoid, and the pia. The dura mater is the tough outer layer that extends to S2, creating the thecal sac. It adheres to the posterior longitudinal ligament and is separated from the vertebral column by an epidural space that contains fat and vessels. Each spinal nerve is surrounded by dura mater that extends through the intervertebral foramen. The arachnoid mater is the thin transparent membrane that is attached to the inner surface of the dura mater. A potential space called the subdural space runs between the arachnoid and the dura mater. The space between the arachnoid mater and the pia mater is the subarachnoid space, which is filled with cerebrospinal fluid and blood vessels that supply the spinal cord. The pia mater is a highly vascular layer that closely adheres to the spinal cord. At the distal end of the spinal cord, approximately L1, the pia mater continues as a long slender strand called the filum terminale. The filum terminale descends through the subarachnoid space to the inferior border of the thecal sac, where it is reinforced by the dura mater. So the spinal cord and nerve roots. The spinal cord functions as a large nerve cable that connects the brain with the whole body. It begins as a continuation of the medulla at the inferior margin of the brainstem and extends to approximately the first or second lumbar vertebrae. The spinal cord tapers into a cone-shaped segment called the conus medullaris, the most inferior portion of the spinal cord, and is located at approximately the level of the first or second lumbar vertebrae. At the termination of the spinal cord, nerves continue inferiorly in bundles. This grouping of nerves has the appearance of a horse's tail and is termed the cauda equina, extending through the lumbosacral foramen. The spinal cord is composed of white and gray matter. The white matter comprises the external borders of the cord and is more abundant. The gray matter is composed of nerve cells and runs the entire length of the cord. Just outside the intervertebral foramina, the ventral and dorsal roots unite to form 31 pairs of spinal nerves. 8 of these nerve pairs correspond to the cervical region, 12 belong to the thoracic region, and 5 correspond to the lumbar region. 5 respond to the sacrum, and 1 belongs to the coccyx. Here we have the cranial nerves, the thoracic nerves, the lumbar nerves, the cervical nerves. Basically, just kind of illustrating to you how complex the innervation of the human body actually is. So here we have a cervical vertebrae, and we have a nerve actually coming out, and we have pretty much the spaces. We have the epidural space consisting here. Then we have the dura mater, subarachnoid space. And we have the pia mater, and the arachnoid. Very difficult to kind of discern. Basically, we're never going to be able to actually demonstrate these adequately on CT, but you do need to just know that these three meninges actually exist. So, as we saw, we have contrast medium in the spinal canal, and we have the cauda equina, and notice how it has kind of a scattered type of appearance. That's what we're looking for. That is the cauda equina. And so one thing that is kind of difficult to discern, but we have this running here. This is the sciatic nerve. You hear of patients having sciatica, and that is typically when this nerve has some abnormality, something is pressing on it. Also, we have several different things here, such as the femoral vein, femoral artery, femoral head, acetabular bladder, sciatic nerve, and greater trochanter. All of this will be covered once again when we actually get to the lower extremity. Here we see at L2, the spinal cord becomes kind of tapered down, has like a cone-shaped appearance there. That is the conus medullaris, and then we reach the end of S1, the filum terminale, and then we get to cauda equina. We have also the subarachnoid space, and then we have the epidural space, the dura mater, arachnoid, and the pia. That brings us to the plexuses. The spinal cord is enlarged in two regions by the cell bodies and nerves that extend to the extremities. Cervical enlargement extends from the vertebral bodies of approximately C3 through C7, and the lumbosacral enlargement occurs within the lower thoracic region. The cervical plexus. The cervical plexus arises from the upper four ventral rami of C1 through C4 to innervate from the neck, lower part of the face and ear, the side of the scalp, and upper thoracic area. The major motor branch of this plexus is the phrenic nerve, which is formed by the branches of C3, C4, and upper division of C5. The left and right phrenic nerve can be slightly different lengths. The right phrenic nerve runs along the lateral wall of the superior vena cava and right atrium of the heart. The left phrenic nerve courses lateral to the left ventricle of the heart. Also, the brachial plexus. The brachial plexus is a large complex network of nerves arising from the five ventral rami of C5 through C8 and T1. The roots sacral plexus are arising from L4, L5, and S1 through S4, the nerves of the sacral plexus, innervate the buttock, posterior thigh, and feet. Most of this nerve network continues into the thighs, the sciatic nerve, which is the largest nerve in the body. The sciatic nerve exits the pelvis through the greater sciatic foramen and continues to descend vertically along the posterior thigh.